Okay, let's take another example of conventional antipsychotics. So let's talk about, um, we've talked about pimozide. Sulpride, we'll talk about it later on. Now let's talk about Zuclopenthixol or Clopixol. Let's go. Zuclopenthixol or Clopixol aquaphase. Um, it is dopamine receptor antagonist, conventional antipsychotic. The type is theoxanthine. Theoxanthine. Okay, dopamine 2 antagonist. It's not used in USA, so it's not approved for anything, FDA, but it is commonly prescribed for acute schizophrenia, oral or acetate injection, and for maintenance treatment of schizophrenia, orally or even as decanuate injections. It can be used for bipolar disorder and for aggression, of course. How the drug works? By blocking the D2 receptors, to reduce the positive symptoms. How long until it works? It can improve within few days, but it makes 1 to 2 weeks for notable improvement. We are talking about, injections, and for oral psychotic symptoms also can improve within 1 week, but can take several weeks for full effect of behavior. We will not go through a lot of these things. We'll just pick the important things about this drug. Okay. Okay. It is used for positive symptoms of schizophrenia, of course. We've talked about that in many typical antipsychotics previously. So let's just ignore these. You can check them later on. What about side effects? The side effects are because of the dopamine blockage in nigrostriatal, pituitary, and other sites. Anticholinergic, antihistaminergic, and antiadrenergic side effects. We have notable side effects like extrapyramidal symptoms, tardive dyskinesia, priapism, galactorrhea, rare lens opacity, these things. So we can here note that we have some life-threatening or dangerous side effects other than neuroleptic malignant syndrome and seizures. We have neutropenia, respiratory depression, and agranulocytosis. It can cause weight gain significantly and sedation, of course. Okay, about dosing, we have oral, acetate, and decanuate. Oral can be taken as 20 to 60 milligram per day, acetate 50 to 150 milligram every 2 to 3 days, decanuate 150 to 300 milligram every 2 to 4 weeks. We have more than one form of formulation: tablets, acetate, and decanuate. Acetate and decanuate. How to dose? For oral administration, initial with 10 to 50 milligram per day is divided doses. In divided doses can increase by 10 to 20 milligram per day every 2 to 3 days. Okay, maintenance dose can be administered as a single nighttime dose. Maximum dose generally 100 milligram per day. Injection should be administered intramuscularly in the gluteal region in the morning. Acetate generally should be administered every 2 to 3 days. Some patients may require a second dose 24 to 48 hours after the first injection. Duration of treatment should not exceed 2 weeks. This is for the acetate, not to exceed 2 weeks. Maximum cumulative dosage should not exceed 400 milligram. Maximum number of injections should not exceed 4. But for decanuate, you can initiate with 100 milligram. After 1 to 4 weeks, administer a second injection of 100 to 200 milligram, and maintenance treatment is generally 1 to 600 milligram every 1 to 4 weeks. About some dosing tips here. Onset of action of the intramuscular acetate formulation following a single injection is generally 2 to 4 hours. The duration of action is generally 2 to 3 days. Zuclopenthixol acetate is not intended for long-term use and should not generally be used for longer than 2 weeks. Patients requiring treatment longer than 2 weeks should be switched to a depot or oral formulation of Zuclopenthixol or another antipsychotic. When changing from zuclopenthixol acetate to maintenance treatment with zuclopenthixol decanuate, administer the last injection of acetate concomitantly with the initial injection of decanuate. The peak of action for the decanuate is usually 4 to 9 days. And doses generally have to be administered every 2 to 3 weeks. Treatment should be suspended if the ANC is below, 1000. Overdose, sedation, convulsion, extrapyramidal symptoms, coma, hypotension, shock, hypo or hyperthermia, and so on. For long-term, zuclopenthixol decanuate is intended for maintenance treatment, so you can use it for that, but not the acetate as we said before. Some side effects may be irreversible, like tardive dyskinesia, as many other conventional antipsychotic. How we stop that? For oral formulation, you can slow titrate over 6 to 8 hours, over 6 to 8 weeks, even with cross titration, of course. And you should be careful about, rebound psychosis and so on. About pharmacokinetics, zuclopenthixol is metabolized by 2D6 and 3A4. For oral formulation, elimination half-life approximately 20 hours, acetate 32 hours, and for decanuate it's 17 to 21 days with multiple doses. So for interactions, so theoretically, concomitant use of 2D6 inhibitors such as paroxetine and fluoxetine, or 3A4 inhibitors such as fluoxetine and ketoconazole could raise zuclopenthixol plasma levels and require dosage reduction. Okay. While inducers of 3A4 like carbamazepine could lower zuclopenthixol plasma levels and require dosage increase, of course. CNS effects may be increased if used with other CNS depressants, of course. Anticholinergics can potentiate their effects. Epinephrine may lower blood pressure. This is okay. Zuclopenthixol may block also the antihypertensive effects of drugs. We've talked about a lot of these in other antipsychotics, conventional antipsychotics. They are similar. Okay. We have other warnings or precautions of these. Okay, let's read them. If signs of neuroleptic malignant syndrome develop, treatment should be immediately discontinued. Use with caution in patients with epilepsy, glaucoma, or urinary retention. Decanuate should not be used with clozapine because it cannot be withdrawn quickly in the event of serious adverse effects such as neutropenia. Possible antiemetic effect of zuclopenthixol may mask signs of other disorders, and cough reflex suppression of that may cause asphyxia. Okay, that's it. Okay. You don't use this drug with angle closure glaucoma or pheochromocytoma or such things. Let's go to some art of psychopharmacology. We have some advantages for this drug because you can use decanuate for non-compliant patients, and in emergency use cases for acetate injection as acute injection, but with disadvantages for children, elderly, and patients with tardive dyskinesia. Primary target symptoms are positive symptoms of psychosis, negative symptoms of psychosis, or aggressive symptoms, of course. We have some pills here. Zuclopenthixol depot may reduce risk of relapse more than some other depot conventional antipsychotics, but it also be associated with more adverse effects. Can combine acute injection with depot injection in the same syringe for rapid onset and long duration effects when initiating treatment. You should know that. Zuclopenthixol may have serotonin 2A antagonist properties, but these have never been systematically investigated for atypical antipsychotic properties at low doses. Patients have very similar antipsychotic responses to any conventional antipsychotic, which is different from atypical antipsychotics, where antipsychotic responses of individual patients can occasionally vary greatly between one atypical to another. We've talked about, switching and polypharmacy. You know about that. So that's it. That's it about Zuclopenthixol. You can read this for more.